This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
Site neutrality has been something we've been talking about for nearly a decade, particularly when it comes to post-acute as well as surgical care. It's just happening slowly in different parts of the care continuum, as well as across the country in different states.
Welcome to Sg2 Perspectives. I'm your host, Trevor DaRin. We're going to try something a little new today. I have three of our most senior voices from the Sg2 intelligence team: Chad Giese, who leads our service line practice; Mike Humphrey, who leads our segments, AMCs and children's and others practice; and Rebecca Limestall, who leads our enterprise strategy practice. I asked them to react to some of the many healthcare articles that come across our desks, and I'm sure come across your desks as well, and get our quick take on it, knowing that they each look at our work and work with our members through totally different lenses and capacity. I bet they're going to have different takes on many of the articles we've seen in the news recently. Probably a little more rapid fire today than sometimes we're used to, but I think it'll be really fun. Chad, I'm going to go to you first. A big piece of news around Longitude Health, exciting partnership. Bill Woodson mentioned it in his comments recently. Everyone's paying attention because they've set some pretty ambitious goals. They've structured it in a way that looks like they're taking this really serious and have thought about, we're going to need CEOs with experience to lead these different verticals. Obviously, huge scale across four enormous health systems. Why do you see this as big news?
Yeah. Hi, Trevor. This is an interesting collaboration across four organizations. And it brings to mind this quote from another one of my favorite podcasts that's called Make Me Smart. And none of us are as smart as all of us. This is what this collaboration here brings to mind. They're working on some of the biggest challenges that health systems are facing, and they're realizing we're not going to outcompete each other on structure or what markets we're in, but we need to do better, and we need to compete and go to market with a suite of capabilities that are maximized for our organizations. And I really like the three initiatives that they're starting with. Costly therapeutics, that is top of mind for almost every organization that we work with today, especially when you start to roll out some of the cell and gene therapies. These treatments are coming with price tags that were inconceivable just a few years ago. Care coordination. This is looking at your high-cost patient populations and finding ways to increase the quality of care that is delivered. That is near and dear to my heart as managing a service line team of researchers. This is something that we're in every day and trying to think about care redesign and the impact on utilization and outcomes. And then finally, around transparency, there's a big gap in what patients have access to and when they get access to it, not just care, but the information that goes along with it. I'm excited to track these. Longitude Health might create a foundation for the future.
I always love looking at non-merger and acquisition type models, creating a new structure to drive change. For a little bit of background, this is Baylor Scott and White, Memorial Hermann, Novant, and Providence, who've come together to create a for-profit holding company that is funded by each of those systems fully. What they're doing is investing in innovation that goes beyond the scale of ownership and allows them to try new things in different markets. That is really intriguing. The business model is something that's fascinating and something I want to watch to see what types of things can they do, what types of things won't work in that model, and how will we be able to leverage that to change healthcare at other organizations.
Yeah, Rebecca and Chad, it has such a near-term operational feel to it. So issues of today, pricing, performance improvement. This is so different than what Verizon is doing, a long-term play with value-based care versus a HATCO that is really banking on a technology platform. So it's interesting that all of these leading organizations are picking lanes, near-term, long-term. But it is nice to see that they're collaborating with each other to find these solutions rather than trying to go it on their own.
I agree, Mike. It feels like boots on the ground impactful. But what is truly going to make our organizations better? They've narrowed down to a list that I'm eager to watch.
Mike, let's flip to the other side of scope of impact here. There's a great article showing some exciting advances from Mayo. They revived an at-home cardiac arrest patient, but the physicians were remote. There was other providers in person. That's aligning so many things around access to care, access to specialty care in rural markets, thinking about system reach. Obviously, there's a virtual layer, but it just seems like it's a different level of impactfulness and putting the pieces together to make it work. And the opposite side from huge national impact, super small local impact. Why is it a big deal to you?
My parents live in a very rural area. I would love to know that if they were in this circumstance, that someone like a Mayo Clinic with this technology could have been there for them. So it's a bit personal for me growing up in that area. And even knowing when I'm at home, I can't even get significant cell signal to make a call. But I think this is all about that idea of access and expertise and a technology. Obviously, technology has come a long way here. What I find interesting, not only because this was life-saving, but really where the origin of this technology came from, initially deployed in the field in military situations. And I think in many ways, we probably don't recognize the contributions that the military has made in terms of innovation in healthcare. Everything from robotics to infield trauma to prosthetics and advances there. Yes, for me, this is an important technology because it does bring that expertise to a rural environment. It also points out that there are a lot of other areas to learn from in terms of innovation in healthcare. The military is certainly one of those. I can see a lot of applications. Certainly, as you think about a younger workforce enjoying time in virtual reality, moving into this type of profession and employing it for the benefit of society.
It points out that innovation isn't dead. We're finding really interesting ways to leverage technology outside of what is typically headline catching today, the GLP-1s or new heart valves or something bigger and splashier. These smaller innovations and technology advancements are still impactful, and there's still a lot of room in healthcare for people to bring their best ideas to solve smaller, more simple situations.
Don't worry, we'll get back to GLP-1s. One more article that fits in this bucket of thinking about how systems and others across healthcare are looking at scale, specifically from Stat News, thinking about some of the benefits of pharmacy benefit managers, PBMs. Mike, I know you've heard opinions from providers all over the spectrum in terms of what they think the future could be for PBMs.
It is a hot issue right now. One of the things that was interesting at the recent health conference, the leader from Blue Cross Blue Shield California said PBMs are a dead man walking. If anything caught my attention, I'm like, wow, we're all aware of some of the FTC scrutiny and even some of the state activities around either limiting or monitoring the activities of PBMs. And in part, it's just because it's such a mysterious and non-transparent business model. PBMs have been around almost as long as pharmacy has been around in terms of managing claims and the necessary ecosystem for healthcare systems, for self-insured employers, as well as health systems. The real challenge is people are looking at the profits that are generated from this. The big three control about 85%. If you look at the big six, it's 95% of the business are controlled by these PBMs. And what's shocking is that for every 40 cents of supposed savings that are generated, those don't go to the pocket of the employers or the providers. It goes directly to the PBM. So they're getting a significant amount of their supposed savings. And the question that people are naturally asking is that the right model that should exist? You're seeing alternative models jump up. You're seeing healthcare systems get into this, creating their own PBMs, leveraging their own pharmacy and technology platforms. You're seeing other models that are being proposed in terms of flat rates. You're looking at cost plus from Mark Cuban, where it's sort of a flat rate plus 15%. PBMs are necessary to manage all that activity and to develop these formularies, but where the savings from these rebates and other type of sort of obscure business practices, that's going to keep it in the headlines and probably will have bipartisan support for some type of reform. Whether they're dead men walking or limping, we're going to find out soon.
I'm going to use that to talk about some other news in an area we always track, which is what's happening with payers, payviders, and then the PE investment world. Let's start with Optum. Rebecca, I'm going to ask for your reaction. They're always in the news. Two recent articles, one about divesting, selling off some of their MedExpress urgent cares to UPMC in Pittsburgh. Another article, totally different vein, around a partnership with University of Minnesota to help during provider education, get them prepared for value-based care success. Two totally different angles. How do you weave it together with what else we know about Optum?
Optum's a huge organization, and they are taking on various bets across the ecosystem of healthcare. They're able to do that because of the scale, because of the balance sheets that they have, and they're able to invest and try different things in different markets. Now, I like the example out of Minnesota because that's a good investment in how healthcare is changing and making sure our physicians are prepared for that. We've seen similar innovations across the country as med schools continue to embrace broader areas of focus and getting physicians up to speed on things like how they will be paid. How is healthcare changing? How to use virtual capabilities? How to use AI?
I'll make a quick, hopefully not too unflattering of a joke related to this curriculum. A good number of these physicians coming out of the University of Minnesota will probably become employees of Optum in some form or fashion later on. Yeah, I do think it's wise. We're asking physicians to be part of this solution, and oftentimes these complex situations around value-based care and how they act and make decisions are central to that. The one thing I will say around the express cares, if you look at Optum, they may be going up the food chain away from what we would call primary care, looking for more of the specialty pieces.
One thing that we've seen is that being on an island in healthcare is very difficult, whether it is a site or a physician group having some connectivity to a larger system or a larger network of providers has shown to be beneficial. And whether that weighed into their decision here and the urgent care connected to a health system might offer more value than being a standalone facility. I don't know the details, but we've seen it across other parts of the healthcare ecosystem, whether you're talking freestanding emergency departments or surgery centers that aren't connected to a health system. We're seeing it play out in various ways across different access points.
Chad, SCA is part of Optum. They recently acquired a CV group. That's something we've heard rumblings could happen for a long time from the PE side. How's that fit into the way you're seeing their landscape?
The activity on the PE side within CV has been interesting to follow over the last few years, specifically around the ambulatory surgery center side of things. And the recent announcement that they've acquired National Cardiovascular Partners, which is an ASC ownership group. They have about 21 ASCs across the country, which is surprisingly large for a PE firm that is specifically focused on CV. These are small numbers relative to the overall number of cath labs or procedure sites specific to CV. The PE's recognizing SCA picks up an ASC-focused organization. There's a lot to say about that in and of itself. Why did National Cardiovascular Partners need someone to help them out?
I'm going to talk about the impact of some local and national policy. Rebecca, I'll go to you first because I know you've done a bunch of work on this. Indiana announced trying to rein in hospital prices through doubling down on some site neutral rules. There's been a handful of other states that have been pushing the envelope on things like CON, cost containment. Is this a trend? Are states going to lean in more?
State policy is something that we have to pay attention to because that's where a lot of the movement is occurring, particularly as it relates to outpatient surgery, reimbursement models, ASCs, things of that nature. The Indiana example, this is House Bill 1004, and it didn't change the reimbursements of the ASCs. What it did is remove the facility fee from any Hop D that is not within, I think it's about 250 yards of the hospital. So there were a lot of Hop Ds that were technically Hop Ds, but off the hospital site. And this removes that facility fee payment, moving to more of a site neutrality impact. What also happened this last year is Tennessee's changed their CON regulations as well. A lot of changes there. Happy to talk with anybody about those specifically because there's a lot of changes across inpatient and outpatient, but it does lighten the restrictions, particularly for ASCs that are owned by hospitals in particular. So there's a lot of movement there that will allow for greater adoption of ASCs. Now, other things we watch, we have the example out of Vermont where there is cost oversight. Trevor and I have been spending a lot of time with a few folks up there, working with them. There's a cost oversight board and gained a lot of teeth in the ACO era. And there's been some cost oversight ramifications this year as University of Vermont has announced that they will not be open what would have been the first ASC in the state of Vermont because of some of those cost oversight decisions. So a few different things playing out that play on different sides here. So watch the state policy. That's where a lot of the movement is.
One of the things, Rebecca, this reminds me of is if we can't layer on those facility fees either to ASCs and or multi-specialty practices that might be doing procedures in their sites, they're going to be less attractive perhaps for acquisition, either from hospitals or private equity. So it concerns me that we might have some of these more challenged sites of care that could have benefited from being either invested from externally or being part of a health system being looked at much more intensely because the revenue associated with them won't be as great in the future. Are there going to be some additional troubled assets out there? Who will look for them? Any thoughts on that, Rebecca?
Site neutrality has been something we've been talking about for nearly a decade, particularly when it comes to post-acute as well as surgical care. It's just happening slowly in different parts of the care continuum as well as across the country in different states. It's the reality, and maybe it does change the financial landscape, but we're actually going to embark on some work on what does it mean to be an ambulatory first organization if we were to think about that first how does that change the way we make decisions as opposed to layering the overhead that we may have from the inpatient chassis?
Chad, I'm going to come to you for the last question. Easy little topic here for the lightning round. Impact of GLP-1s. We pay attention, especially this time of year as we're building the forecast. 2 quick articles we were circulating. One says GLP-1s won't save the day. The other shows how big of an impact it's already making in bariatric surgery volumes. How do you see it across your service line and others?
Oh my goodness, this is a hot topic and one that the service line research teams are constantly diving into because there is a whole bunch of pushes and pulls here that will inevitably have an impact. I would say there are a couple new reports that have, in addition to what you just mentioned, so yes, bariatric surgery, we've seen a very large decline, even year over year, in the number of surgeries. So sometimes headlines are really catchy. They get you to click. What's really interesting in that report was 95% of obese patients still were not treated with any obesity management program. And so while we saw a significant decline, there is a huge population that is still out there untreated. That was also represented in the recent NHANES data drop from the end of September that pointed to a flattening of obesity rates. It also found that 12% of the US population has tried a GLP-1. 6% remain on a GLP-1 year over year. So we still have a long way to go. Doesn't decrease the impact that these drugs have at an individual level. I think as our teams are looking at the national impact, though, we're taking this across populations. We still have a bit of a runway before that epidemiology of disease is truly impacted to the same degree that we've seen with statins or to the same degree that we've seen with some of the other treatment modalities like PCI versus CABG. It's certainly fascinating to watch, and there are pockets where we see significant changes in use rates at a national level. We've got a bit of a ways to go.
And I would just add, it's expensive. And corporate organizations, employee-based health are putting structures in place to where this isn't the first line of defense. It requires quite a bit of compliance with various types of management first.
Yeah, Rebecca, I think that's a great point. And the equity issue here closely related to affordability is significant with this. And we're in an interesting time. Which populations will this impact and at what magnitude? But the affordability and the equity of it are certain questions we're going to have to come to. And that almost gets back to that PBM issue around what formularies and what restrictions will be structured around it.
Rebecca, Chad, Mike, thank you so much. This was even more fun than I expected. And with so much in the news, I feel like we just could have kept going. Thanks so much for sharing your perspectives. Always so valuable. Look forward to having you on again soon. Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, Sg2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.